Welcome to this video on obsessive-compulsive and related disorders. This lecture is designed for basic science students to provide an overview of the biology, presentation, and management of OCD and its related conditions. This video is compiled by Perry Barton Dakal, PharmD, MBA.
In this video, we will define OCD and explore the spectrum of related disorders. We will examine the etiology, including genetic and neurobiological factors, identify clinical features, apply diagnostic criteria, and outline current evidence-based treatments.
OCD is a chronic psychiatric disorder characterized by recurrent, intrusive thoughts known as obsessions and repetitive behaviors known as compulsions. These compulsions are performed to reduce distress or prevent feared events, not for pleasure. Typically, patients recognize these thoughts as excessive, and the disorder causes significant functional impairment. The historical perspective of OCD has evolved significantly. From being described as scrupulosity in the 17th century to being classified under anxiety disorders in the DSM-3, it has eventually been recognized as a distinct category in the DSM-5, now termed OCD and related disorders. The DSM-5-TR chapter on OCD and related disorders includes several conditions, such as body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation disorder, among others. Both the DSM-5-TR and ICD-11 maintain similar frameworks for classifying these conditions. Both group them under specific chapters for OCD and related disorders and include the core conditions, though there are minor differences in secondary categories. Epidemiologically, OCD has a lifetime prevalence of approximately 1 to 3% worldwide. It is a bimodal disorder, with early peaks in childhood and later peaks in early adulthood. Unfortunately, there is often a significant diagnostic delay of 8 to 10 years before treatment begins. This chart highlights the estimated lifetime comorbidities associated with OCD, showing the frequent co-occurrence of other conditions that clinicians should be aware of. The etiology of OCD is best understood through a biopsychosocial model. This includes genetic vulnerability, neurochemical dysregulation, maladaptive cognitive appraisals, and potential environmental triggers. There is no single cause. Rather, it is a complex, multifactorial interaction. Genetic factors play a strong role in OCD. Family studies indicate a 4 to 8 times higher risk for first-degree relatives. Heritability is estimated between 45 and 65%, though genetics generally confer susceptibility rather than absolute certainty. The neurobiology of OCD is linked to the CSTC circuit, involving the orbitofrontal cortex, caudate nucleus, and thalamus. Hyperactivity in this loop can lead to faulty filtering of thoughts, while the anterior cingulate's involvement in error detection creates a persistent "something is wrong" signal. Neurotransmitter hypotheses emphasize the role of serotonin, given the response to SSRIs. Other neurotransmitters like dopamine, glutamate, and GABA are also implicated, with glutamate now becoming a target for newer treatment agents. Neuroimaging findings support these theories, showing volume changes and increased metabolic activity in the OFC caudate thalamic loop. Significantly, successful treatment with CBT or medication has been shown to help normalize this hyperactivity. The autoimmune theory, known as PANDAS or PANS, suggests that certain infections can trigger an abrupt onset of OCD symptoms in children. This occurs through molecular mimicry, where antibodies against an infection may cross-react with basal ganglia neurons. Finally, the behavioral model explains how classical and operant conditioning maintain the cycle of OCD. Because compulsions provide temporary relief from anxiety, they are negatively reinforced, strengthening the cycle. This understanding serves as the foundation for exposure and response prevention therapy. The cognitive model posits that OCD arises when individuals misinterpret common intrusive thoughts. Key cognitive processes involved include thought-action fusion, inflated responsibility, an intolerance of uncertainty, and the paradoxical effect of thought suppression, which only serves to increase the frequency of unwanted thoughts. Obsessions are defined as recurrent, unwanted, and intrusive thoughts, urges, or images. They are ego-dystonic, meaning they conflict with a person's values and cause significant anxiety. Importantly, these are not simply worries about real-life problems. They prompt the person to try and neutralize them through other thoughts or actions. Obsessions often follow common themes. These include fears related to contamination, concerns about causing harm, a rigid need for symmetry or exactness, the presence of unwanted taboo thoughts, hoarding-related fears of losing important items, and excessive focus on somatic sensations. Compulsions are the repetitive behaviors or mental acts performed in response to an obsession. Their purpose is to reduce distress or prevent a dreaded event, rather than to provide pleasure. They are typically rule-bound and often seem excessive or unrealistic in relation to the feared outcome. Common types of compulsions include excessive washing or cleaning, repeatedly checking locks or switches, ordering and arranging items to achieve symmetry, counting, performing mental rituals like silent prayers, and seeking constant reassurance from others to confirm that things are safe or correct. Insight into one's condition is an important specifier in the clinical evaluation of OCD. DSM-5-TR distinguishes between patients with good or fair insight, poor insight, and those with absent insight or delusional beliefs regarding their symptoms. Assessing insight is clinically crucial. It helps in distinguishing OCD from psychotic disorders, as OCD themes are typically recognizable. Furthermore, poor insight is a prognostic indicator of greater symptom severity and may necessitate adjustments to treatment, such as higher medication doses or augmenting with antipsychotics. To meet DSM-5-TR diagnostic criteria for OCD, a patient must present with obsessions, compulsions, or both. These symptoms must be time-consuming, typically taking over an hour a day, or cause clinically significant distress. Furthermore, the symptoms must not be better explained by another condition, substance, or mental disorder. The severity of OCD is categorized as mild, moderate, or severe based on functional impairment. Cases with poor insight often present with higher levels of disability. It is also vital to screen for comorbid depression, as it significantly elevates the risk of suicide in patients with OCD. The differential diagnosis for OCD requires careful consideration. Clinicians must rule out other conditions that present with repetitive thoughts or behaviors, including anxiety disorders, tic disorders, and certain neurodevelopmental conditions, to ensure an accurate diagnosis and appropriate treatment plan. Comorbidity is highly prevalent in OCD. Depression is the most common, affecting up to 2/3 of patients. Other frequent co-occurring conditions include anxiety disorders, tic disorders or Tourette syndrome, ADHD, autism spectrum disorder, and various eating disorders, all of which share features like rigidity and rule-bound behavior. For assessment, the Yale-Brown Obsessive-Compulsive Scale, or YBOX, serves as the clinical gold standard. This instrument allows clinicians to quantify the severity of both obsessions and compulsions, aiding in diagnostic precision and the monitoring of treatment progress. Beyond the YBOX, other tools are used in clinical practice. The children's version, CYBOX, is adapted for pediatric use. Self-report tools like the OCIR and the Florida Obsessive-Compulsive Inventory provide brief screening options. These tools are essential for tracking patient baselines and responses to treatment over time. OCD typically has a gradual onset and a chronic, waxing and waning course. Prognosis is generally better with good insight, later onset, and treatment adherence. Conversely, early onset, poor insight, and comorbid depression are associated with poorer long-term outcomes and a higher likelihood of residual symptoms. Treatment for OCD often involves a combined approach. For mild to moderate cases, cognitive behavioral therapy with exposure and response prevention is first line. For moderate to severe cases, an SSRI is added. Refractory cases may require augmentation or neurostimulation, while psychoeducation remains vital for both patients and their families. Pharmacotherapy primarily involves selective serotonin reuptake inhibitors, or SSRIs, as first-line agents. These include fluoxetine, sertraline, paroxetine, fluvoxamine, and escitalopram. It is important to note that OCD typically requires higher doses than those used for depression, and the onset of action is delayed, often taking 8 to 12 weeks to show a significant response. Clomipramine, a tricyclic antidepressant with potent serotonin reuptake inhibition, is a highly effective, albeit second-line, medication due to its side effect profile. Because of potential anticholinergic effects, sedation, weight gain, and cardiotoxicity, it requires careful monitoring, including regular ECGs and blood level checks, especially at higher doses. Treatment-resistant OCD is defined by an inadequate response after 2 adequate SSRI trials. Management strategies include augmenting SSRIs with low-dose antipsychotics like risperidone or aripiprazole, or under specialist supervision, combining an SSRI with clomipramine. Emerging evidence also points to the use of glutamatergic agents and intensive CBT programs. Psychotherapy for OCD is centered on cognitive behavioral therapy, specifically exposure and response prevention. This involves gradual, systematic exposure to feared stimuli while the patient refrains from performing compulsions. This process facilitates habituation to anxiety, while the cognitive component challenges distorted beliefs like inflated responsibility and thought-action fusion. For severe refractory cases that have not responded to multiple interventions, neuromodulation and neurosurgical options may be considered. These include non-invasive repetitive TMS, deep brain stimulation targeting the ventral capsule and striatum, or in rare last resort cases, ablative neurosurgery like anterior capsulotomy or cingulotomy. We now transition to body dysmorphic disorder, a condition characterized by a distressing, persistent preoccupation with one or more perceived flaws in one's physical appearance that are not observable or appear only slight to others. Clinical features of body dysmorphic disorder include intense focus on specific sites like the skin, hair, or nose. Patients often engage in repetitive behaviors to alleviate their distress, such as frequent mirror checking, excessive grooming, skin picking, and seeking constant reassurance, often paired with camouflaging techniques to hide the perceived defect. The DSM-5-TR criteria for body dysmorphic disorder include preoccupation with perceived defects, repetitive behaviors or mental acts, and significant clinical distress or functional impairment. A specific specifier exists for muscle dysmorphia, where the individual is preoccupied with the belief that their body is too small or insufficiently muscular. Body dysmorphic disorder has a prevalence of about 1.7 to 2.4%. Onset typically occurs in adolescence, around age 16 or 17. It shares significant genetic and neurobiological features with OCD and is notably prevalent among individuals seeking cosmetic or dermatologic procedures, despite such interventions rarely providing lasting relief. Treatment for body dysmorphic disorder mirrors the approach for OCD. SSRIs, often at high doses, serve as the first-line medication, alongside adapted CBT incorporating exposure and response prevention. Crucially, clinicians should avoid recommending cosmetic or dermatologic procedures, as they rarely improve the underlying disorder and can often worsen the patient's condition. Hoarding disorder is defined by a persistent difficulty in discarding or parting with possessions, regardless of their actual value, resulting in the accumulation of items that clutter active living areas. The core feature of hoarding disorder is driven by a perceived need to save items and significant distress associated with discarding them. This leads to severe congestion in living spaces. Insight is often limited, with many individuals failing to recognize the problematic nature of their behavior. Diagnostic criteria for hoarding disorder involve persistent difficulty discarding items, distress associated with parting with them, and significant clutter that compromises the use of living areas. These symptoms must cause significant distress or impairment and cannot be better explained by another mental or medical disorder. Hoarding disorder has a prevalence of 2 to 6%, often increasing with age. While symptoms can begin in adolescence, they typically worsen over decades. The condition involves complex cognitive deficits, including issues with decision-making and categorization, and commonly co-occurs with depression, ADHD, and other anxiety disorders. Treatment for hoarding disorder requires specialized CBT, focusing on organizing skills and decision-making. Harm reduction strategies, such as home visits and practical support, are often essential. While SSRIs may be used, evidence is weaker compared to OCD, and the condition is generally considered to be chronic and more treatment-resistant.